Right. Well, they're finding their places. I'll do some introductions. So closest to me is Cathryn Edwards, who many of you will know as the organizer of this meeting, the senior secretary of the BSG, and in clinical terms, a consultant gastroenterologist in South Devon. Cathryn, thanks very much for coming. Next to me now is Richard Russell, paediatric gastroenterologist at York Hill Hospital in Glasgow and chair of the Busgan IBD working group. Richard, good morning. And then the two other panel members are Roz Prescott, we've not met, hello, thanks very much for coming. Roz is a BBC regional political producer and an ambassador for Colitis and Crohn's UK. And finally, Jeremy Taylor, who is Chief Executive of National Voices, a national coalition of health and care charities for England. He joined in 2009, a year after its launch, and the charity's grown to have a reputation as a strong, independent champion for patients, for carers, and for the voluntary sector. And last but not least, Jonathan Freedland, who we're very grateful to for coming along today to chair this, is executive editor of the Guardian newspaper, amongst many other attributes which are available from Googling his CV on Google. I won't go through this in detail, but I note, Jonathan, that in 2002 you were voted Journalist of the Year, and the judges praised you for your incisive, original, strong, and very outspoken views. Jonathan, I think you'll find other people in this room with similar attributes, and we're very happy, or I'm very happy, to hand over the floor to you to moderate this panel discussion and draw out some of the themes that we've heard so far. Thanks very much indeed.
Thank you. Thank you, Stuart, for that warm introduction. Very glad to be here. I'm guessing one of the most dangerous places to be in this city is between a group of gastroenterologists and their lunch. So I'm going to try and keep it quite to time and stick as closely as we can to our targeted end time. As Stuart suggested there, my qualification for being here is that I'm the least expert person in the room, but journalists are very used to trying to turn ignorance into a virtue. So I'm going to do that, I hope, and bring a sort of lay view to this as we sort of try and steer through and draw together some of the strands of all the different discussions that I've been sitting listening to, and all of you have been as well. I've come this morning from the daily editorial meeting at The Guardian where the editors of all the different sections get together, and I hadn't even thought particularly about this process until listening to all of you this morning. The thing we do is compare data, and we have extremely precise data on every article that is published online, a figure, a sort of ticking clock that is showing before your very eyes. Every time somebody clicks on it and reads it, the number goes up. We can see what's doing well, what time of day, where people read it in the United States, Britain, Germany, etc., whether they read it on a desktop, laptop, mobile, did they come to it via Twitter or Facebook or because through the Guardian front page, etc. Incredibly detailed data. We wouldn't be able to do our jobs, it strikes me, now without that kind of data, and it's just been fascinating for me to hear about this field where there's an argument going on about exactly how to collect the data and use it, because in my own field it's now become essential. So that's interesting to me. I thought the first thing we would do is turn to you, Cathryn Edwards, and get from you, if you can, a kind of distilled version. I know we've heard so many different arguments, but in a nutshell, what to you is the case for this kind of data collection and to be done in the way that we've been hearing?
Well, thank you, Jonathan, very much, and thank you to the audience. It's a great opportunity to talk as a collective about this. In a nutshell, the driver for this is patient benefit. We are doctors. And specifically, that might be at local level with good sharing of data which drives best clinical practice and efficacy and safety. Or it might be at national level where pseudonymized data would be used as a measurement and reporting of quality metrics and benchmarking of performance. In terms of national service planning, I think there's a real win here for monitoring, recording the resourcing of service and service planning, and the monitoring that allows us to look at the equity of service provision across the UK. And finally, and probably not least, is the fact that we are being challenged now at the level of a public health agenda to deliver disruptive innovation that's going to transform our healthcare services in gastroenterology at a time where we are financially constrained. And I think the option here to take hold of the IT revolution and use that in terms of the way we collect data on patient monitoring direct from patients themselves, wearing devices, uploading data, that's our challenge. And if we don't do that, we will lose the opportunity to continue to improve quality service at a wider patient footprint than we're doing at the moment.
And just before we get a reaction to it, just say something more about equity. That's interesting to me. Why would data help you provide a more equitable or fairer service?
Well, we talk about postcode lottery in medicine.
Yeah.
And I think until you know the demographic of your patient cohort for whom you're trying to provide service, you will have no idea about whether there is equity in distribution of services across the country and whether there's equity of access to those services. Good.
Okay, I'm going to try and make sure all of you have a sort of opening shot, and then I want a free-for-all, and we're going to then broaden out so that we hear some of the voices in the room here. I was struck, Keith Bodger said in the end of his presentation, you've got to have stakeholder engagement. Surely the lead group of stakeholders are patients. You've heard a powerful case from Cathryn Edwards for why it should be done. I'm turning to you, Roz Prescott, on what you think patients, what hesitations, if they would have any, what question marks they might have about this, or whether you think they're gung-ho and keen on this.
Well, personally, me as a patient, I'd be so keen on this. It's a simple idea, one that I can't believe it hasn't been thought of as yet, but, you know, in 2015. But to me as a patient, it's a given. Yes, you've got questions with regards to the registry about safety, your identity, your personal information. You know, in the world we live in these days, you know, there are hackers out there, things can happen, but I'm sure the professionals would secure that. I would like to think they would, but with regards to having a registry, and plus what Kath said as well, and a portal linked, it's just music to my ears as a patient to have all that information on there. It's so valuable. I was late, unfortunately, to the conference this morning due to the fact that I had a hospital appointment at Guy's, and I saw a clinician that I hadn't seen before, and she sat me down and spoke with me, but I had to tell her my whole health history from
the beginning.
Honestly, and this is why I was delayed, unfortunately. And I was actually discussing with her why it was just ridiculous to think you can't just click a button and have all your information there at one click of a button.
So from your perspective, there would be enthusiasm for this. It seems obvious and logical. Yeah. But you did mention some of the worries that some patients would potentially have about the safety of their data, the confidentiality of it.
Absolutely, yeah.
And there was a row about a year ago or so about this data.care, I think it was called, yeah. A scheme to digitize and make and store all that data. And in the end, it was sort of, they stepped back from that because of concerns about confidentiality. And your faith, some people would say, was very trusting, saying, I'm sure the professionals would take care of it. Actually, you've seen, you know, if Sony Pictures' entire database could get hacked, surely the IBD registry could get hacked. Who on this panel would want to reassure patients on that point about confidentiality? Is anyone going to step up about the safety of the data? I'm open to any bids or offers on this point. Richard, I'm going to look at you. Do you want to talk about that? Or no? Because I'm thinking there will be patients who will be worried about it. So.
I mean, I think there are justifiable concerns. However, I would say that the alternative is no better. And if you walk into any hospital these days and you see piles of case notes lying around with no security on them at all, and that is absolutely people's information just lying around. So no system is perfect. There are chances for breaches in confidentiality, but I suspect they're actually significantly less than existing models. And I would also say that we, maybe this isn't right, but we trust our personal information to the banks, which use less secure mechanisms than are planned for the registry.
And Jeremy Taylor, you're listening to patients' voices all the time. That's what you do. People, I think, it's quite true what the point Ian makes about banking data, but there is something amazingly personal about your medical data. And I would venture to add, in this area, IBD and those things, people feel it's a tremendously intimate, you know, series of problems, and would be even more reticent about people. You know, people, they might not mind people knowing about a cough and a cold, they wouldn't necessarily want anybody else reading this kind of data. Where are you on this issue, the safety of the information?
Well, I mean, quite a lot of research has been done on public attitudes and patient attitudes to information. And I think I'd sort of echo what other speakers have said. The evidence is that most people, first of all, they want the NHS to use their data properly and sensibly. They want to be able to have access to their records. They don't want to have to tell their story over and over again. And they just want, you know, we want people to sort out the ridiculous slowness in getting systems to join up. When it comes to people's data being used for purposes other than their own direct care, the evidence is that most people are quite happy with that. In fact, many people would want their data to be used in order to improve service design, in order to contribute to research. And that's the vast majority. But people expect the quid pro quo is the data is protected, it's confidential. The people who look at it have got a good reason to look at it. So they don't want any old Tom, Dick and Harry looking at their data. And yes, they don't want it to be hacked. But I think, you know, we're all wising up as a population. We know that there are risks. I think what we want is for sensible rules and safeguards to apply and actually penalties to apply where there have been breaches. So I think where there's a proper and transparent system of rules, most people will be happy for their data to be shared. And I think one of the problems with care.data and all that is that the legitimate concerns about privacy and safety of data have sort of trumped all the progress around doing the sharing that's going to make a huge difference for quality of care, which is very frustrating.
And we'll leave this aspect in just a moment, but just on that last thing, because you mentioned pseudonymized data. Would it be anonymized or pseudonymized? Is that how you imagine it working on a full rolled out IBD registry?
Yeah, I think so. Pseudo-anonymized, at least. I think, you know, the data that goes out beyond the individual sites cannot have identifying tags.
Okay, so that's obviously only one aspect. It was one that was flagged up. But Richard Russell, do you want to get into the broader case and perhaps take on board some of the other barriers that were suggested and just sort of reassure us on those? Quite interesting, that finding that it's more difficult to get this happening where it's consultants rather than nurses, this issue of consultant time. You know, the IT is notoriously difficult as an area. Can you confidently leap over some of those barriers for us?
I certainly prefer that question to the last one you asked me. So, I mean, I think, you know, I'm just reflecting on the fact of, you know, the young patients that I see in clinic and how they would see this whole discussion. So teenagers would laugh at this discussion that we're even having it. So we saw about the internet access figures for the population, but all teenagers have access to the internet. All of them use smartphones. All of them like to communicate, particularly about IBD, in an indirect way often. So they don't like to sit down and go over what is often for them a very long history. So if they were, unfortunately, in Rosalind's position where they'd been diagnosed as a child and then moved to adult services and then nobody had their whole history and they had to go over it again, they might be going through 20 years. So I think, you know, they, particularly the patients we look after, would support this and would laugh that really we haven't caught up with information technology in a way that they can use and access that they're used to in their daily lives. So I think we need to do it for them because, you know, they have the disease for the longest. They're most at risk of complications of the disease. So it's a duty to all patients, but particularly to them, to move this process
That's very
forward.
interesting. So in other words, you've turned the confidentiality argument or the sort of personal argument around and said actually it's less intrusive this way because you're not having to retell your whole story again and again.
And this is what they're, you know, used to doing every day. So I mean, they're sharing all parts of their life over the internet and through social media. And if you ask, you know, David from a Crohn's and Colitis UK perspective, this is how things have taken off. This is how the organisation is moving forward. This is how there's a much greater input now because social media have opened up in Crohn's and Colitis UK.
Yeah.